Okay, hello and welcome everyone to the SHISMD webinar, Patient Share of Care, the single metric to measure health system growth success. SHISMD would like to extend a sincere thank you to HSG Advisors for sponsoring today's program. This webinar is now being recorded and is broadcast in listen-only mode. We have designated time at the end for Q&A, but feel free to click the chat icon in the lower right-hand side of your screen to submit questions or comments throughout the presentation. It is now my pleasure to hand it over to today's speakers. We're joined by DJ Sullivan, who is the Chief Strategy Officer and Managing Director of Claims Data at HSG Advisors, and Travis Ansel, who is the Chief Executive Officer at HSG Advisors. So DJ and Travis, thank you both so much for joining us. The floor is yours.
Thank you. All right. Thank you so much, Tom. Welcome, everybody. Appreciate your time on a Wednesday afternoon, or at least it is here in Louisville, Kentucky. Today, we are talking about patient share of care, the single metric to measure health system growth success. This is an exciting topic for us. This is a proprietary measure that we developed that is being leveraged by a number of health systems in the country, but for a very specific reason that we're going to talk about today. And so we look forward to bringing that to you. As Tom mentioned, our bios are in the presentation, but DJ and I have a tremendous amount of background in working with hospitals and health systems in their approach to their strategy for their market and providers. And we do that in the context of HSG Advisors, of course. So for today, I want to get a little bit of an overview on why we call patient share of care the single metric for measuring health system success. DJ will go into a deeper definition of how we think about patient share of care, what it measures, and why it matters to health systems. And then we'll talk through some common approaches to patient share of care, one of which is market-based and one of which is population-based. And we'll talk about what those mean and why some health systems choose to use one or more of those. And then we'll talk about, what other measures do you look at in order to make patient share of care, a relevant metric within your health system and move it forward. So jumping in, the reason we call this the single metric for measuring health system success. So patient share of care was developed in 2017, and we were working with a quaternary academic center, has a number of community hospitals. And when you start thinking about a statewide network of hospitals, drilling down to there's so much noise in terms of we know that we need to be able to profitably grow, and we need to be able to measure our success in profitable growth. We know that if we're looking across hospitals, employed physician groups, outpatient settings of care, we have a lot of leadership members, we have a lot of stakeholders involved in trying to drive an organization forward. How do we have all these different measures out there. How do we determine if we are having success as a system? And how do we make that a transparent metric, which can go on something as simple as our, executive scorecards in terms of, something we put in front of our board and governance in terms of putting in front of our, service line leaders and employed networks. How do we have one metric that is common to all of us so that we're all measuring success the same way? And so, we developed this as a pilot in 2017, thinking, this makes a lot of sense for academic centers and, big statewide networks, because, they really need that. And what's been really fun for us over the last 7 years in terms of working with organizations is, we found that this is pretty much relevant to every health system right now. So while some organizations, scaling all the way down to some of our smallest critical access clients, may not have some of the infrastructure and may not have some of the, huge leadership teams that we're trying to organize on the same page. We still find pretty much every health system kind of struggling with this dynamic. How do we have a measurement that overall focuses our executives on, creating financial sustainability for the organization? And how do we cut through the noise of our balanced scorecard and our pillar approaches to have one metric that kind of drives all other activity? And it doesn't mean that we can't still have other objectives and other goals, but how do we have something that kind of sits on top and says, if we are doing all these things right, this is the number that's going to increase. And so, as we worked on putting this together, and of course, we'll, through our next couple sections, kind of define this for you. We call this the single metric because for the organizations that use it, it does tend to become the predominant metric for measuring leadership success, organizational success, strategic planning success, and overall kind of growth success. And so that's why we call it the single metric. And then DJ, you will jump into kind of defining that for everybody.
Yeah, thanks. So, one, great background, Travis. So, taking a step back, so what is patient share of care is obviously a great place to start. This, from our perspective, almost has to take a step before that to take into account what most other industries term as share of wallet. So, if you're in something like consumer goods, as the example on the screen, where there's very specific industry standards and measurement around if a individual spends money on coffee. I'll walk through the example a bit more specifically, but someone, if I spend money on coffee, how many of those dollars am I spending with Starbucks versus someone else? And so that is a very standard metric and measurement from other industries that has never really been applied to healthcare, or from what we've seen applied to healthcare in a very meaningful and applicable way. And so talking through an example of what's on the screen. So it's really a great metric of ultimate brand loyalty is, so you can see the kind of Investopedia share of wallet, the dollar amount a customer, regularly spends on a specific brand as opposed to competing brands. So that's where we're trying to get to from a healthcare standpoint. We see the example of, if you look at the individual cups of actual coffee sold, like that is one way to consume coffee goods, where you can say, based on which location you're at, I bought 10 cups of coffee in the month of August. 4 times I was at a Starbucks, so I bought there. There was a Dunkin' Donuts more locally available, had better access at one point, so I bought 4 cups there. Then there were 2 other local and or random coffee shops I also utilized. So if you were to look at market share from that perspective, you would say that me, DJ, I spent 40%, or Starbucks is capturing 40% of my coffee consumption from that perspective. However, that's a very individual and very central focus to my total coffee consumption. So if you move to the right-hand side, is everyone on the call, on the webinar already knows, there's lots of ways to purchase coffee. You can buy stuff at your local grocery store to bring coffee and make it at home. There's coffee substitutes. You go to a gas station and there's all the other branded other types of coffee type goods that are also available for purchase, as opposed to just individual cups. And so if you maybe looked at me from that approach, then I'm going to say, of all the coffee type services I consumed and purchased in the month of August, these numbers are obviously very fake, but we'll say I spent $25 on Starbucks branded elements, about 7.5 on Dunkin' Donuts branded coffee goods. And then I also had some other, like I said, random coffee brands that also fell in there. So if you looked at from a share of wallet perspective on my total consumption and purchase of coffee goods, is actually closer to 70% of all my dollars spent were on Starbucks branded services, or not services, but on coffee goods for this example. So translating to the next slide, how do we apply something like that to healthcare is really like the lens we as HSG came from. How do we take something that's very standard and applicable to other industries? How do we apply it to healthcare? And so, one, we need to identify which individuals, which people are we talking about? So we have, like Travis said, we'll walk through a number of specific use cases of types of populations we may be focused on, or that we think you should focus on. But let's use the example of, let's start with just our employed primary care patient panel. If we start with just that patient population, if we looked at from an inpatient discharge perspective, it might be very, very similar to the Starbucks example we saw a second ago, where maybe they're patients on our primary care panels, but they actually have a random discharge at certain facilities just based on access and their ability to actually get into those sites of care. So that's potentially a very narrow view. However, what we want to translate is then shifting to the right. What's maybe more important to us is of all the dollars those primary care patients are spending on their healthcare, how many cents of every dollar are they spending at all of our facilities? So, how many cents are being spent on not just inpatient services, but outpatient services, physician practices, labs, imaging, all those other types of services that patients are going to be receiving care around? Of all the dollars spent, how often and how many cents of every one of those dollars are we capturing within our health system and our specific brand to measure, like we said, a measurement of brand loyalty as an example. Shifting to like a very specific example then is, let's use something like an orthopedic patient, where I'm going to start at the very end, or maybe from an individual lens, what we see in the industry a lot is a lot of hospitals and health systems. If we had to ask you what's your share of knee arthroscopies on the inpatient side, or even the outpatient side potentially, like most organizations have a great representation of what that looks like. They can say, no, there were 1,000 knee arthroscopies done. We did 450 of them within our operating rooms. We had a 45% share of knee arthroscopies done for patients in a certain geography. That aspect of the care continuum, there's lots of great data and measurement around, or that we've seen. It's all the other aspects of the care continuum where it gets really fuzzy, and how do we bring it together? So, one, for that patient to receive a knee arthroscopy, if we kind of start now back at the top left, there was probably some sort of initial orthopedic visit that may or may not have come as a referral from a primary care provider. Maybe it was just patient knew they had some sort of pain in their knee, so they immediately scheduled with an orthopod. There's most likely a number of follow-up visits where, there may have to be reviewing of imaging results, some sort of therapy or injection that's going to take place. Let's then circle back on, did therapies work? Did the injections work? Those types of things where there's a continual sequence of events that's going to take place before we even get to the actual knee arthroscopy, saying that's what we need to be doing for this patient. And so for that specific use case, then how do you measure the success of all those other service arrays and where all that service is being done? And are you capturing it comprehensively as a hospital or health system? And how do you build the infrastructure to do that well? So as we get into best data elements to actually do that, to be able to look at the comprehensive universe of total healthcare spend, what does that look like? How do we measure success around it? We see lots of different approaches that we see organizations trying to utilize. It doesn't always work out, perfectly, but being able to, we have lots of comments and questions around just the anecdotal, well, this is how we feel. This is what we feel is happening in the marketplace. Ideally, that should never be a metric on a scorecard anywhere of how you feel. But we do have lots of organizations that like to use that as a way to make decisions. A better approach, obviously, is going to be a lot of your kind of inpatient and or hospital outpatient department data that you may have to your state hospital association, other elements like that. That obviously is very robust data for the most part. It is, however, reliant on how that data is reported. And two, it often misses a lot of all the ancillary support services of imaging, labs, physician practices, a lot of those other elements, home health visits, a lot of those other parts of the care continuum obviously get lost in that type of data set, which, maybe those aren't the highest dollar things, but depending on what your organizational strategy is, if you're a community-based hospital, as an example, which we'll talk about more, your ability to capture imaging and labs might be your most important way to optimize the financial capabilities of your organization. So you need to be able to have those insights available to you. The EMR, we find that often becomes, if people are trying to utilize their electronic medical record, it becomes a lot more referral-based measurements, things like that. And it's also siloed, obviously, to just what's within the EMR. It doesn't capture anything outside of your walls. So not a great way to really think about, overall measurement of total patient spend. And so our recommended approach is using obviously an all payer claims type approach. There are obviously lots of gaps that exist that or potentially exist within a claims based approach to measurement of anything, because there's no one source of truth for every single claim that's processed across the country. There are good data sets, there are better data sets, worse data sets. So that's one area as you begin to evaluate these things, just be, cognizant of what's available, what are the pros and cons to which type of claims-based approach you're using. But we do feel from our third-party perspective, that's the best approach to comprehensively put together thoughts around inpatient services, outpatient services, physician practices, imaging, labs, more or less the comprehensive continuum of care. That's going to be the best approach to have a bigger picture, kind of overall holistic portrait of what that looks like. And so there's, pros and cons to everything, but that's one thing that if we're looking at it comprehensively, we think and have found that to be kind of the best approach to begin to measure something as kind of a single source of truth for where our organization is going. So the last thing I'll touch on quickly before transitioning back to Travis for case studies is some big picture observations we have on kind of how you leverage and should leverage something like a patient share of care or share of wallet metric is being very specific about what patient population you're focused on for growth. We'll walk through approaches or different approaches we see where that's going to be very specific to your organization. Once you have that very kind of defined well, really being focused on how do we socialize and integrate some of those metrics into key performance indicators on a system level scorecard. Is it practice specific? Is it population health specific? Like based on your organization, where does that information need to live? And then we'll touch on at the very end, ensuring that whatever that metric is fits into kind of your strategic plan and growth initiatives and has supporting elements to help make sure you're driving in the right direction, is going to be very critical to make sure that you actually see a change and an ultimate impact on where your organization is trying to go.
Great, thanks, DJ. So kind of jumping into common approaches to patient share of care. So why do we have multiple approaches? And DJ touched on it a little bit. So we think claims data is by far the best data set that gives you a comprehensive view of the market, allows you to see the entire care continuum, allows you to see your performance and your competitors' performance, both from a health system and other healthcare entity perspective. So claims data, we feel, has to be utilized for this. Now, anyone who's worked with claims data, one of the real challenges with claims data is there's not a patient, there's not a defined, patient resides in this zip code data point anywhere on commercial or any of the commercial-based Medicare products. So that is always restricted. And so for organizations like us that work with claims data, we have our methodologies for attributing patients, at least down to a county level. But when you're talking about something with like patient share of care, which, for some organizations could be, just your historic primary and secondary market, could encapsulate something as small as one county. It could be as big as, the entire state in some cases for some of our clients or a multi-state region. We have to develop an approach that allows us to really think about what population of patients are we trying to measure the behavior of, and which, for that patient population, how do we get to what they are spending on healthcare and what portion we're capturing of it. So we have two common ways that and a lot of this has been driven kind of by our clients, asking us, different questions of here's what we're trying to do, how do we best apply that to the population. But the first thing we're going to cover is what we call market-based share of care. So an example of this that's in the case study here in a few slides is, we have a client who has a 5-county market, very urban, a lot of in-migration from outlying areas because they, as the tertiary, quaternary kind of market, are drawing patients in. And so, one, it's hard to define, the entire footprint of where their patient population lives. And you would get a lot of noise as you start getting, instead of a 5 county market, you might get to a 40 county market that they're actually drawing from. So we do what we call a market-based share of care. And this is, let's define the geographic area that we care about. And let's utilize claims to identify all patients who are seeking healthcare within that 5 county region. So it's not they live there. It is they are actually seeking, they are making their healthcare decisions and utilizing care within that market definition. So that's as the examples of common applications, that could be primary and secondary market definitions. That could be a single county, a multi-county market, a statewide market. But it says if a patient is seeking care within this geographically defined region, we care about them. We want to know what they're spending on healthcare. We want to be able to measure ourselves against our competitors within that market. An alternative approach, and the one that we started with, is what we call a population-based approach. And so this ignores geography. And this says for a given population of patients, and there are many, many ways to define population of patients, what percentage of the healthcare spend are we capturing for that population? The most common population-based share of care metric that we utilize is basically all of the patients who interact with primary care within your market. And so for some of our clients, that is just their employed primary care or employed and aligned primary care. For some of our clients, it's a totality of primary care in the market, all the patients who are seeking primary care within that market. And so to put that into an example, the one that we started with, where we developed this metric, they have a number of primary care physicians across the state that they compete in, to the point where they have, patient panels of about 250,000 patients. And so we, agnostic of where that patient lives, we see those patients interacting with their primary care providers from a claims perspective. We make that the pool of patients that we say, hey, these are the patients that we should best be able to control. They are seeking primary care through us. We're the front door to every other health system or site of care in the state. We want to retain as much of that patient population's volume within our network as possible. Now that's one common approach. For other organizations, some have looked at that a little more broadly. Yes, Travis and DJ, we care about our employed primary care practices, but we also care about patients who are interacting with our emergency department, patients who are interacting with our urgent care, patients who are utilizing us from an inpatient or hospital outpatient services perspective. Patients, and some organizations have also taken to using this as a competitive metric. We want to see all the patients who are not interacting with us, but who are getting their care delivered by all the other health systems we're competing with, so that we can figure out how we make inroads into that market, whether that's trying to convert them into our primary care patients, or whether it's trying to disrupt their utilization of the care continuum and bring their specialty and ancillary care into our network. But it's really important, as DJ said, the most important part of patient shared care is really figuring out what is the population that we want to utilize to kind of measure our strategic progress. And then from there, figuring out how do we build strategy around it. So talking through the market-based approach a little more. So what does that look like? So here's a handful of blinded slides of what that measure looks like. So if we're talking about a client that is using this market-based approach. So the first thing that's really important to us is that this data gets trended over time. So as you see on both these graphs, this is not a measurement at a point in time. This is a measurement and management metric that is updated quarterly. And we ideally see the progress that, from where we have executed our strategies, our growth strategies, we should ideally see our total share of care, increase over time. So when we're looking at the graph on the left, where we see, for the market that we're measuring, we see approximately between $6 and $7 billion of healthcare being delivered. Our client, you can see in the dark red bar that they differentiated, what they think of as their health system, because they have, their kind of owned and operated facilities and physician practices, but they also have a number of joint venture relationships. And so within this market-driven population, they wanted to know, we want to be able to see what's just us. We want to be able to see us with our joint venture partners. We want to see all of the dollars we're not capturing over time, and what opportunity there is for us out in the market. So the way to read this bottom left table, so total health system share of care, in Q1 21, they're capturing 46.8 cents of every healthcare dollar delivered in that market. And that they had some serious attrition over a 2-quarter period where we saw a major change, and can't really talk about the reasons behind that. But it did give us it did give them the measurement to say, hey, the challenges that we experienced over that time frame were very real. And our overall capture of the healthcare dollar, regardless, like DJ said, of market share, which measures procedures, this is actual dollars. So our dollars that we were capturing, dropped off precipitously. And we can take that down to, what's shown here on the right. We can break that out by payer so that we can look at, we see a lot of, especially, competitive markets where there might be 2 or 3, competing health systems within that same market definition. That's where it sometimes is very helpful to take that overall share of care metric and break it out by payer to understand, for the commercially based population and our Medicare Advantage patients, how are we doing in attracting that population versus how are we doing versus attracting, a Medicare fee-for-service, Medicaid, and other population. So thinking about this, again, market-driven population approach. So if we have an overall metric, to us, the next place to go is, well, let's drill that down into the various sites of care that allow us to see, how are we doing relative to our competition in each of the, inpatient, outpatient, physician office buckets, and how relevant are those to our overall, to capturing patient spend. So you can see in this graphic, the biggest sources of expected reimbursement, as you might expect, are in the hospital outpatient department, as well as the hospital inpatient department, with ambulatory healthcare facilities and physician offices being a smaller component of that. If anybody has attended our webinars before, we are very, very, very pro ambulatory and pro physician office in terms of your strategy, because that really is the front door for unlocking those dollars that are in the inpatient and outpatient environment. But this does give us a nice blended scorecard of, when we think about share of care, from a physician office perspective, how much of that care are we actually capturing that's being delivered there? And how is that feeding our inpatient, outpatient, and other ambulatory healthcare facilities within the market? And how are we doing relative to our competition? How many dollars are out there for us to incrementally capture? So that's what we look at there. And then we can also even drill that down by service line. So we start to look at, real variation by service line. So for this client, you can see, they did a very strong job, and we can differentiate how they did in cardiovascular, capturing about 37 cents of every commercial dollar out there, while capturing, close to 42 and an additional 15% with their joint venture partners, but capturing a much more substantial part of that governmental and other payer cardiovascular service line. And that being, from a commercial perspective, that being kind of one of their worst service lines in terms of percentage capture. In general surgery, they're close to 50%, orthopedics, they're close to 50%. So this gives us the idea of, one, what are the relative dollars that we're chasing by service line? So not all service lines are created equal. And where should we be looking in terms of growing our overall share of care? And then we can even take that down, since we're, again, utilizing claims, we can take that down to the subservice line level. So if we're thinking about cardiovascular on both the inpatient and outpatient side, is that medical cardiology? Is it cardiac surgery? Is it vascular cath? What are the opportunities in terms of the net dollars of market reimbursement that are available to us, and what portion of it's ours? And of the portion that's not ours, where is it going, and how are we going to build a strategy to go after it? So using this as an example, so that sample 5-county client that uses a market-based population approach, they have gone to the extent of integrating that as their top line strategic planning objective. Our aspirational goal is to grow to 34% share of care from somewhere in the mid-20s. But they are attaching, kind of everything. So share of care is the top level metric which we then drill down and say, how are we doing from an access strategy, or all the things we consider our front door strategy? How are we doing from our other ambulatory sites of care? How are we doing from our specialty services that, we're trying to drive volumes to and retain patients within? And, for the various new business, secondary market, and payer strategy to improve reimbursement, how do all of those things align to increase our one single metric, that we're measuring success by, which is patient share of care?
And I
So,
think,
go
good.
ahead, DJ.
No, I was going to say one addition I might make to this is that I think it's important to note, if you depend on how you work through these strategies, because there's obviously lots of X's that feed to the Y. And so this is oftentimes very long-term targets or initiatives, like back to where Travis started, like that single metric. So that 34% actually is a little outdated, where that organization is now looking at a 2030. So they have a 5-year share of care percentage target that they're working towards. There's obviously then X1s, X2s, et cetera, that flow into what they believe is ultimately driving that strategy. But it's kind of that North Star of where are they trying to get to, and how do they pull each of these different levers to help them achieve that target.
All right. DJ, will you talk about population-based approaches?
Yeah, so the difference here is, so as Travis articulated to start, a market-based approach is looking at what's the total spend in a certain geography. Patient-driven populations are kind of where this initiative started with us, like Travis said, 7, 8 years ago now, of being able to identify which patients do we believe are having the largest impact on our organization, and how do we start to prioritize measurement around those. This example, and kind of what we'll talk through a little bit more, is around kind of academic health and the academic health system partner, where really focusing on starting with primary care for most organizations is where we recommend, where you can look at, maybe there's an overall metric. So they like to break things out based on, is it our pure employed primary care patients and or urgent care patients? And how are we going to track and trend that measurement across time? So you can see in Q1 21, about 68.9% of every dollar was being spent at their locations. And that shifted down to about 66.5%. We do, however, also have what is that actual expected spend and reimbursement, which for this organization is about just over $1 billion. So they're, I want to say, about a $4 billion system. They've identified that 25% of that total patient spend is coming from employed and or urgent care patients specifically. We're going to measure what are the actual number of those patients, and then start to differentiate either by practice and by region. What does that difference look like? So we can see our employed group region A, we're capturing 60 to 65 cents of every dollar. However, if you get into our employed group B, then we're actually upwards of 70, 75 plus. So what is the variance by each of those different markets, so that we can identify where's going to be our most immediate opportunity, understanding that a dollar or a percentage increase at each location is not and should not be created equal. That a 1% increase across employed group A is going to be equivalent to about a $5 million increase, while the 1% increase in region B is actually only going to be about 1.5 million. So, understanding that the components of market share differences in capture rates are going to be different and should be treated differently. Shifting to the next slide, thinking about incremental access points for this. So these are probably the most common patient populations that we get questions around. If we're thinking about a patient-driven approach, where we're saying patients within our ACO, that's the patient population we care about. What's the total spend of those ACO patients, and how often are we capturing? What percentage of all their dollar spend are we capturing? How does that look like for just ED patients, for our employed primary care patients, et cetera? So these are probably some of the more common access points that we see, a lot of them primary care based and or ED based. So those entrance points being extremely important. But one thing I'll call out is there's no real limitation on how you identify patient populations. I think that's important, especially based on your organization and your size, that they can be very customized to you. And so spending a little, we found over the years, you learn through trials, but being able to say a little bit extra time identifying an appropriate patient population for what you're trying to exceed is by far a much better way to measure overall ROI on the time and investment you're making. So spending, like anything, a little bit more energy on the forefront is kind of continually paid off for a lot of the examples and elements we've walked through with clients. Then there's two specific examples I'll look at. So this is first that kind of academic health system approach. So this is kind of on their organizational health system KPI within, a $4 to $5 billion health system. There's individual overall health system share of care metrics around their employed primary care patients specifically, as well as then we work through kind of regions or practices, depending on how what your terminology may be, and being able to identify differences there. But then they've put, once again, very specific targets around what they think is successful, both from a region perspective and then for a service line within each region perspective, and then globally as a health system. So there's service line targets, region targets, and health system targets, kind of saying what's ultimately driving, and all of those elements being kind of key initiatives within kind of what they're saying is their overall corporate dashboard and KPIs. I think one thing to note that I might have skipped on is we do like to utilize what we term as expected reimbursement. So a lot of, especially if you use a claims-based approach, most claims I'll have a charge amount, relaying and sharing out actual payer or reimbursement information is very seldom or if ever available. And so we typically work with our partner clients to make adjustments based on charges are X, we expect to collect, Y percent or, whatever number that is based on your actual contracts of both commercially and for with, other payers. And so making some of those adjustments and working hand in hand is worth the time and energy to more or less make those appear to be, as close to real figures as they can be, because it becomes a very financially driven metric. So shifting to a community hospital view. So this is where we probably have some of the most variation in how this gets structured, is when you get into individual community hospitals, because the needs are very different. So we oftentimes actually recommend having multiple share of care metrics when you get to kind of the community hospital level, where it may be specifically, you can see the example on the screen where one, we most likely care about our employed primary care base. We think that's probably global across every hospital and health system, regardless of your size. If you're community-based, you also probably care on the right-hand side about your ED patients specifically, where you can see you're capturing, in this example, if we're HSG advisors, the dark red, we're capturing about 35 cents of every dollar from our employed primary care patients, about 21 cents of every dollar from our ED patients. And then if we kind of roll all of our sites of care together, inpatient, ED, primary care, specialty care locations, urgent care locations, et cetera, we're capturing about 23 cents of every dollar, the kind of big middle pillar. And so we want to be able to understand, based on actual access points and sites of care, how does our share differ? Because our strategies need to be different to actually overcome and improve each of those separate metrics. So that's where it gets back to being very thoughtful about what's your organizational goals and targets, and how do you ultimately have that be the target, but having the infrastructure from a data perspective built to actually be able to, have inputs that can lead to those ultimate outputs. So this just gives one more quick example of maybe a potential variation that would exist, whether it's the left-hand side is your employed primary care patients, the right-hand side is our emergency patient population, and between even those two patient cohorts, we may see, for this specific example, upwards of 8%, 8 to 9% overall share of care difference based on just how those patients and individuals utilize the care continuum, and what can we keep in the system or not. When you get into specific service lines and sub-service lines, there may be even greater variation in what that looks like. One anecdote to that, so we've measured this for obviously lots of clients across the country. One of the most significant I've seen was we had a very different strategy with a client on employed primary care locations versus they had what they called like urgent immediate care locations. And between those two sites of care, their share of care percentages was, I think, 20 to 25% different, if I recall correctly, where urgent care, it was a very urban market, urgent care locations, their brand loyalty for those patients was very, very low. They were capturing maybe 40 cents of every dollar. If a patient came into their urgent care, no matter what they try to do around an education standpoint, et cetera, their ability to keep those patients within the system was very low. However, their established primary care patient panels, they were capturing 65 to 70 cents of every dollar. And so they had a very huge focus on urgent care, education, transition of care, all those types of elements that becomes the tactics that can improve the overall measurement capability. But it's elements they felt a lot of those things. They had anecdotes of a lot of those things, but there was no way to measure and manage those. And so we were obviously able to help and kind of work with them to build a lot of infrastructure to do that well and have it continue to be a kind of KPI moving forward.
Great, thanks, DJ. So related measures for supporting patient share of care growth. So again, that's our measure and management metric. So what are some of the other metrics that we typically see, when we try to drive patient share of care growth? What other metrics do we need to be aware of? So some of those DJ's already hit on. Inpatient market share typically is the easiest for especially for hospitals and health systems that are contained within one state, and as long as that state's not one of the handful that don't aggregate inpatient data well. For multi-state systems or systems, on the periphery of a state where your market extends into 2 or more other states, we typically utilize more of a claims-based inpatient market share measure, but we have to be able to measure that piece of the market. Similarly, we also have to be able to measure outpatient market share. And so at a minimum, there are a handful of state hospital associations that collect okay to good hospital outpatient department data. There are very few states that collect some limited ambulatory data. So to us, if you're really trying to measure the outpatient market, so what is my percentage of all physician office and medical cardiology CPTs, that really has to be a claims-based metric as well. Something that we do quite a bit. We do for a couple of states, but we do for a number of health systems across the country as well. But having that measure as what the corollary to the inpatient side, very important to be able to measure and manage against as we're trying to drive patient share of care. A third part that we is purely a claims-based metric to us is what we call provider market share. So whereas outpatient market share might measure our performance by service line or subservice line, just like an inpatient market share data point would, provider market share is how we think about measuring market share at the specialty level. And so the differentiation that I commonly use is, when you think about something like endoscopy. If you are in a urban market at a relatively large facility, your endoscopy is probably done by a gastroenterologist. If you're at a community hospital in a rural facility, your endoscopy is probably largely done by general surgeons. And so when we think about the endoscopy as part of a service line, to us in outpatient market share, that is the gastroenterology service line, because that's what an endoscopy code is to us. But when we think about the variation in what type of specialist is delivering care, provider market share becomes very relevant to us, because it's not just are we capturing the cases within that service line, but what levers are we having to pull in terms of which providers are providing them those cases, in order to understand who do we need to work with and where do we need to capture those cases. So we think that's really important for driving share of care. some measure of patient leakage and retention. So as we're thinking about how we drive share of care, the easiest way for either of those metrics that we've talked about today is starting with your own patient base that is hitting your sites of care now. And so we see a lot of organizations measuring that through EMR, measuring true referrals, and whether those referrals were made in network or not. Again, this is an area where we really prefer a claims approach so that we can see not only what referrals were made, but how do our patients utilize the care continuum. And if someone's going to a neurologist, was that even a referral from our primary care network, or did they get there through some other means? But having measures of patient leakage and retention to say, this is our patient, but they're not staying in network, to us is best practice. And then one of the you know one of the big gaps we see a lot of organizations doing is, we see a lot of organizations doing provider supply and demand, or studies of workforce or needs assessment, but they're generally kind of connected to filling access gaps. And a lot of those decisions are either getting made by, recruitment with the input of employee network leaders or service line leaders, but we're not really seeing that. In a lot of organizations, we don't see provider supply and demand get really attached to kind of our strategic goals as an organization. So it tends to flow through a few different layers. Whereas we think, the dynamics of where is our market oversupplied, what opportunities exist from an undersupply market needs to be kind of directly connected to our strategic growth goals, and therefore kind of directly connected to patient share of care. So that's something that we have to have really good arms around in order to be able to drive patient share of care very well. And then the last part is, we're obviously measuring patient. We've talked about measuring patient share of care at a point in time and doing so, on a trended basis. But one of the things that we have to have our arms around in a really strong way is kind of where's our market going, and how do we project patient share of care, or project the patient population that we're trying to capture? How do we project that going forward? And so, at its most basic, if you're looking at demographics and market projections, there are a lot of great census measures out there that can help us, kind of size how much is our market growing. There's also a bunch of third party and proprietary, companies that do that work specifically. So all of these things are kind of the next level of, not goals, but kind of data set drivers of what do we need to have our arms around and be able to measure in order to be able to drive our patient share of care strategy. So wrapping up here, and then we're happy to take questions. I see there's some in the chat. So again, summarizing what we heard today, patient share of care, as DJ said, there's lots of different ways we can apply a share of care measurement, but to us, best practice is, ultimately there needs to be one single metric that says this is the percentage of care we are capturing from the patient population we care about right now. Here is our plan for growing it over time. And that needs to be integrated across the board. It doesn't need to just be an executive level measure. It needs to be transparent to, leadership, planning, marketing, finance, medical groups, service line leaders, et cetera. DJ emphasized the importance of figuring out the patient population, and what is most relevant for your market. We gave two broad examples in terms of market-based and population-based, and then some subsets thereof. But again, that's really the most important part of implementing a metric like this, is having kind of a laser focus on, again, what population do we care about? From a lessons learned perspective, internal education around a metric like this is critical. To us, looking at history, it takes probably a year to implement, and in that same year to get organizational understanding of. So we can build it very quickly, but the implementation, which involves educating stakeholders, having them understand what this is, why it's important, how we're expected to work together, how it ties to organizational goals. Like that's a realistic first year of let's get it built and let's get it socialized before we ever start trying to really act upon it. So it does lend itself really well, to your next fiscal year. So anybody starting their, fiscal year, probably, start of calendar year 2025 or later, this is the time to be thinking about, how do we, if we start right now, can we get this into our next fiscal year? Or do we, is it more of a late 2025, early 2026 metric? And then overall, like I said, we think this is the only way to really do this effectively is from a claims-based perspective. The philosophy and framework could be applied to other data sets. We just think all those other data sets don't really give us the transparency of the entire care continuum. So again, if you what you heard today and you think through the model and you think, hey, we have data sets internal to us that we could maybe apply this philosophy to, I would say, great, run with that. But I think where you'll ultimately kind of end up is, we need to be able to see the entirety of the care continuum, both us and our competitor, and it needs to be inpatient, outpatient, and the entire ambulatory continuum for it to really make sense and be useful. So with that, Tom, we'll take questions. If you'd maybe like to facilitate that for us.
Yeah, Travis and DJ, thank you both so much. That was great content. Thanks for sharing your expertise. So just a reminder, if you do have any questions, please do feel free to put that in the chat, but we do have a handful to start us off with. So Travis and DJ, let me know if you already responded to any of these, but I'll just kind of go from when they were first submitted. So the first question was, have you considered utilizing mobile data to define markets by geofencing the primary facility?
And I can take this one, Travis.
Sure.
So we've actually found, especially as you would expect, as we start to get into the share of care component, specifically by geography, we haven't used as much to define the population, but we see it used all the time after the population has been defined to increase share of care. So like a specific example, a partner of ours, in Michigan, they defined for orthopedics in their market specifically, based on where the actual practice locations were. They had share of care as high as like 70 to 80% in some regions, and then as low as like individual teens in others. And so they used a geofencing market strategy to do targeted orthopedic ad placements, things like that, on the areas where they had much lower share of care percentage because they thought it was a giant education issue. The services, in their opinion, were competitive in both markets. It was more a education of services. And so they used that as an example, the geofencing, to really have that be kind of like a tactic to increase share of care, but not necessarily as the actual metric itself.
Great, thank you. So the next question is, can you clarify? So when we look at claims, are we looking at actually paid by insurance or the patient or billable charges?
Yeah, I touched on this a little bit before, but if you use a claims-based approach, most claims data sets that we've seen have commercial, on the commercial side specifically, have charge information. So we typically work with clients to adjust charges to what we term based on actual procedures, so down to the procedure level of what the expected reimbursement is for each of those individual codes. So that you can say, yeah, charge is X, is a dollar. We actually only capture 24 cents of that dollar. So make it a realistic fight, or as realistic as it can be as a financial target. So we typically may work with clients to make adjustments based on insurance aspect, et cetera, based on the charge amounts.
Yeah. And further clarifying that, DJ, so for the dichotomy in the question, we're using billable charges, not what is actually paid. And so, yeah, to your point, that does require adjustment because if you're in a market where, it's you as a community hospital versus a, tertiary academic, you're obviously going to have very different charge schedules, very different reimbursement rates. So that's exactly why DJ is focused on, we work with you to make sure that the reimbursement of those procedures in the market is tailored to your organization.
Okay, and then how do you work through regions where you know you have gaps regarding payers?
And I saw that question. I kind of wanted a point of clarification. Is that a gap in terms of the health system's coverage with a payer, or from a claims perspective, our coverage? I would imagine it's the former. and that's to say, we probably wouldn't go to the extent of excluding that volume out, because it really is kind of for that patient population, it really kind of is a true metric of what they're spending across the care continuum, regardless of who the payer is. But that really could become a consideration when we think about how do we build that patient population. So, if you're not working with a major payer in your market, and that looks to be the case, or that has been the case for a while, looks to be the case going forward, thinking about the patient population that we care about that can utilize, our sites of care, that might lead me towards more of a, say, population-based metric where we're kind of targeting or building a patient population based upon who's currently utilizing your sites of care, and then looking at their share of care, for, are we capturing 50 cents on the dollar of all of that care? And, how do we maximize the patient population that is working with us, and a payer that we're obviously working with?
All right, thank you. The next question is, when you are running a patient population share of care analysis, do you need to use some sort of unique patient identifier or token?
Yes, if you were to use a claims-based approach, that's exactly the process where you're most likely not going to identify, you know, who I am, DJ Sullivan, but you can identify based on, let's use the ED patient population as an example. You can, using a claims-based approach, identify who are all the patients that had a ED visit code at a certain geography. That's the patient population that you're focused on. So maybe it was 1,000 patients that hit our ED in 2024. That's the patient population. And then we're going to use those identifiers as kind of is noted to say, where else are those 1,000 people also receiving their care across the entire care continuum? So that's exactly how that process would run from like a logistics standpoint in the background.
All right, thank you. So from a marketing perspective, how can this, as in share of care, be leveraged to target specific providers or markets?
So that actually, Tom, probably gets back more to what I touched on a minute ago, that we've seen from a marketing perspective specifically, being able to prioritize time and energy is where we see having a share of care metric and or metrics is going to be the biggest bang for the buck, because you can, that orthopedic example I gave a minute ago, it very easily is able to identify from a dollar perspective. We spend $1 and have an increase of share. Here, it's going to result in Y. In this other market, it's only going to result in, half of Y. And so being able to prioritize time and energy of where you're spending your marketing dollars and how you're spending them is where we've seen like the most impact from an organizational standpoint, because it's going to be, what's the fastest way to generate revenue for the least amount of spend from our perspective.
Great. And maybe also related, but what types of strategies are required to improve share when there is so much variance by access points? So ED, PCP, etc.
Any comments on that, Travis?
Yeah. So I mean, we always, I think it's a little bit different organization to organization, and kind of within the dynamics of your market. But, we generally kind of work through, you know, one, do we have sufficient access from regardless of the way that we're measuring primary care, or sorry, patient share of care. We generally work with a starting point of what do our access points look like? Are we able to create sufficient access? Do we have the geographic footprint that we need in place to attract the patient population that we're targeting? And then secondarily, we kind of think about, our broader specialty strategy. We apply some of those data points that we were talking about towards the end of the slide deck in terms of measuring our penetration of each market, both from a share of care at the service line level, but also down to the, what does our market share look like? What does our provider market share by specialty look like? What do the provider supply and demand dynamics look like? And kind of shape that into, both geographic growth strategies as well as service line growth strategies, and kind of have those things kind of intersect as a matrix to, what is our patient share of care goal for the intersection of those two things, and kind of build the service line strategy and the growth strategy at the same time, with the focus on, how do we truly increase the share of care metric.
All right, and then maybe we have time for one last question. So if you didn't get your question answered, I think Travis and DJ have their contact information in these slides. But the last one is where do organizations find claims that best represent the outpatient environment and physician practices?
Yeah, most of the time it's going to be through third-party resources such as us as HSG advisors. There's other sources available, but it's typically some sort of third party that you most likely have to kind of work through to access a lot of that data, as it's not publicly available, information but it typically has, additional expense associated with it outside of what's typically, available internally or through some other publicly available source.
All right, well, DJ and Travis, thank you both again so much, and thank you again to HSG Advisors for sponsoring today's program. Please do complete the short survey that will launch on your browser once this webinar closes. A recording of the webinar and the slides will be shared via email later this afternoon. That concludes today's presentation, so thank you all and wish you a great afternoon ahead.
Thank you.
Thanks so much.